going to talk about heart failure. Heart failure is probably the most common volume diagnosis in the Medicare age population once you get to the age of 65 and above. You look at the number of patients who are admitted with heart failure and you multiply that by the number of days they spend in the hospital, it's the biggest diagnosis in all of Medicare. And it affects at least 5 million Americans today are living with congestive heart failure, and many of them are living very, very well. They live good lives in most circumstances. But they're predicting over the next 5, at least even into the 20-year range, another 15 to 20 million will be diagnosed. Part of that because of the boom of our baby boomer age population is moving into the age group where we will start to see an increase of those risk factors that lead to congestive heart failure. What is heart failure? You know, really heart failure is not an independent disease in and of itself. Congestive heart failure is sort of a syndrome. It's a syndrome where you have symptoms based on the fact that your heart cannot supply your body adequately with all the needs metabolically. And you tend to retain water and you tend to retain salt and swell and develop symptoms of shortness of breath, primarily based on that. But it usually is the cause of other things wrong, either throughout your whole body systemically or other things wrong with your heart in general. You end up with a loss of pumping function. It can be a little bit normal with age. We see the heart sometimes isn't quite as strong as we get older, similar to our kidneys and our joints and everything else, but this is a much more dramatic loss in the pumping function of the heart, and sometimes it's due to the stiffness of the heart. The heart with age can become very stiff and not pump as effectively. If we look at the primary causes, if you look at the most common cause in Western civilization, United States, Western Europe, most civilized areas, is coronary artery disease and heart attacks that damage the muscle, the pumping function of the heart. And we've developed technologies over the last 20, 30 years that people survive their heart attacks much more frequently than they did 10 or 15 years ago. But those people that are surviving with heart attacks oftentimes are left with symptoms of congestive heart failure that we need to treat to keep them feeling well. High blood pressure is a potent risk factor for developing a heart failure, even in the absence of its risk of developing a heart attack. And when we look at the risk factors of coronary artery disease and heart attacks, the things to avoid to not develop this, to not develop congestive heart failure, are smoking, overweight, high cholesterol diet, and exercise. All the things that Susie was emphasizing this morning that are important not to go on to develop heart failure and not to go on or coronary artery disease and end up with heart failure. Some of the other things that are associated with heart failure that doesn't fall in there: diabetes, profound anemia, hyperthyroidism or hypothyroidism. Both cases can sometimes lead to heart failure. Abnormal lung problems, emphysema of the lungs, being overweight, and the development of sleep apnea is associated with heart failure as well. This is essentially a picture of a normal heart from the front of your chest, and this here is the main pumping chamber of your heart. It's the left ventricle, which pumps the blood out from your heart once it's been oxygenated from your lungs out to your body. And this valve here is your aortic valve, which is the aorta extends out here and takes blood to your brain and the rest of your body. This is the mitral valve, which brings blood back from the lung, which is now oxygenated, to get it into the ventricle to have it pumped out to your body to give you all the things you need. This is just a brief little color clip. And this is the aortic valve. This is the one that takes your blood separates your heart from your body. And it's a 3-leaflet valve. You can see this kind of shape here. It looks like a Mercedes-Benz symbol. It looks like a 3-piece pie, and that's what the normal aortic valve looks like when it's functioning normally. This one is opening vigorously and looks quite normal. This happens to be your pulmonic valve, which is the similar valve on the right side of your heart that separates your lung from your heart. Again, this is the mitral valve functioning normally, very thin. It's kind of a crescent-shaped valve. It's also saddle-shaped if you look on end, and that's a very normal-looking mitral valve. And this is your heart, kind of cut like a loaf of bread, one single slice through your heart of a heart that's squeezing very normally. Your heart should pump roughly 65% of what's in it is squeezed out every time. It's not 100%, it's not 80%. Usually normal is about 65% of what is inside it. And this is the right ventricle. It's a nice 4-chamber of all 4 chambers of your heart. It's a very common view we look at to look at things over. And here's a picture of a heart that's a lot less happy. This is what we call a dilated cardiomyopathy. The heart is enlarged. It's dilated up. It's not pumping very strong at all. You can tell the heart rate is high because the patient is sick, because each time it squeezes, it's only squeezing a very small fraction of what is normal out the aortic valve. So the heart rate is going fast because they don't feel well. You can see some fluid collecting around the heart because it's backing up from the heart. And here's the four-chamber view, and you can see all four chambers are somewhat enlarged. The top chambers both look enlarged, the bottom chambers look enlarged, and they don't look brisk. And this can happen for many reasons, where people can develop idiopathic dilated cardiomyopathies. It's somewhat rare, but they show up with no explained reason for their heart to be weak. Sometimes viruses, common viruses that you're exposed to, can turn on your immune system in such a way that it attacks the heart and makes it weak. There are treatments for that, and most people recover somewhat nicely. Here's a better picture of a patient who has had a heart attack in the not too distant past, and this is what we call a myocardial infarction that involved the front wall of the heart. This is the septum between the two chambers, and starting here at the mid and going all the way around the front of the heart, where an artery called the left anterior descending has had damage. And this is, again, the front of the heart that has experienced a fair amount of damage from that. And if we cut that heart like a donut again, or a slice of bread, we see this whole section of the heart that is just squeezing weakly. That's one of the reasons you go directly to the cath lab, or why we take patients directly to the cath lab, because the faster you get it open, the less likely are you end up with this damage that occurs like this when the artery is closed completely. I just want to show you one of these pictures. This is a somewhat rare cause of heart failure. This patient's heart actually squeezes fairly strong, but the muscle, if you notice, looks kind of bright. And it's very, very thick, and this is what's called a hypertrophic cardiomyopathy. This patient has developed where the heart just thickens and thickens and thickens, and it doesn't really stop, and it's a genetic abnormality. It makes the heart very, very stiff, and even while in many of the early stages, while the heart squeezes strongly, it relaxes very, very stiffly, and you can have all the same symptoms as you do as if the heart was weak or it had been damaged. Quick picture, you can see how thick it is, and the thickening is fairly uniform, but this area between the two chambers is predominantly thicker, which is a hallmark of this disease in most circumstances. And again, you can see this heart probably squeezes more in the 75-80%. It's very stiff, and it's squeezing more because it has such bulk. You can get thickening of the heart in response to high blood pressure, but not to this degree. And anything that thickens the heart is a marathon runner. It likes to be thin muscles. Anything that extra high blood pressure, any extra resistance will thicken it. It's like doing curls. What's good for your bicep isn't so hot for your heart, because when the heart thickens, bad things happen to it. It becomes stiff and it becomes unhappy. Most weightlifters aren't really good on the marathon course, and neither is your heart if it has been lifting weights. It's heavily calcified and not opening well, and this heart is certainly somewhat weak. It's straining under the impact of that valve. You can vaguely make out what used to be those thin pliable leaflets. This is a heavily calcified valve that no longer opening and is causing damage to the heart, and it's at that point where it needs to be replaced to get it back. And this is, again, a picture of a heart that is very thick and is straining under aortic stenosis. The other and probably most common reason of heart failure among valves, this is the mitral valve, and you see this bowing of this, what we call the posterior leaflet. This is the front of the body, this is the posterior towards the back. This is a bad case of mitral valve prolapse, where the valve leaflet is sinking in very far behind the heart, and it's starting to cause this leaflet to fall in behind the other ones. And we look here and we can see this dramatic leak, this bright color flow into this top chamber as the blood, instead of going out the heart, is going backwards towards the lung. And again, you can see it from here where this leaflet sags back. They don't come together uniform. One leaflet is sagging back, and we get all this mitral regurgitation, which is another common reason. And that leaflet probably is one that can be repaired rather than replaced. Fatigue and weakness, oftentimes those are the most common signs. They can be many other things besides congestive heart failure. Shortness of breath is a hallmark symptom, and shortness of breath oftentimes is either your cardio or your pulmonary systems, but that's one of it. Especially when you exert yourself, you'll become short of breath, or when you lie flat. Sometimes persistent cough or wheezing. You can see swelling. We always, as doctors, we always pull your pant leg up and want to press on your ankles to see if we can make a dent in your leg, just like that, which is a sign of fluid accumulation. And again, everything that swells is not your heart. There are many other conditions that can cause you to swell, but it's one of the signs we look for as evidence that your body is no longer able to keep up, and you're starting to develop this fluid retention that's a hallmark of heart failure. Rapid weight gain from fluid retention that's out of proportion to what you're eating. A sudden weight gain of 1 pound or 2 a day consistently is a sign of heart failure. Dizziness or weakness, appetite, nausea, and certainly rapid heart beating. What do we do for patients with heart failure? What can they do for themselves? This is a very important factor, which I think beyond the medications, beyond what your doctors are doing to you in the invasive laboratories or what tests you're having done, one of the things we want you to do is restrict your sodium. at least to a 4-gram level and optimally closer to 2 grams a day, which 2,000 milligrams sounds like a lot, but if you start reading all those little labels that they put on at the store, you can add up to 2,000 milligrams very fast. People who exercise live longer, they do better, they live with less symptoms regardless of the damage they've had to their heart. Stop smoking if you do, and weigh yourself daily to keep an eye out for sudden weight gains that can alert your doctor. In the event that the heart doesn't get better, there are options, and again, one of the common things we do here is put pacemakers. There's a device called a biventricular pacemaker. It has 3 leads instead of 2. The traditional pacemaker is just designed for when the heart doesn't beat enough, it's too slow. But these pacemakers have a top lead in your top chamber and then 2 leads in your lower chambers, one in the right ventricle and one that goes out to the left side of your heart. And it's not indicated in everybody, but many people who have heart failure, the heart does not squeeze adequately due to a conduction abnormality of the heart, and the heart starts to beat out of sync with the other side of the heart. The heart is weak, but they're not working together. It's kind of like trying to row a boat with one oar or one paddle. It doesn't work so hot, or it doesn't work as good as it ought to. And sometimes if we put that second lead in that we talked about, which this patient had, and if we turn it on, we can make the heart beat together. And this is a package we have on our echo lab to measure how well it beats together. You see all these little arrows, and they tend to come back together. And this person's heart, where the arrows were kind of moving opposite to one another, or moving in the same direction at the same time, are now coming together at the same time. And we're able to improve how that patient feels. And many of these people feel better overnight. If you look at what we've been able to do with heart failure, we've been able to improve over the last 15 years. There's many medications. Many people do very well. Sometimes the medical regimens are somewhat complex in some circumstances, but the trade-off is, bottom line is living longer, living with less symptoms, and living a better life overall, and living back to the normal life and doing the things that people want to be doing. And that's our ultimate goal, is to get people back to what they're doing, not to put them on the couch.
Good morning, everybody. Is anybody here bored yet? Okay, good. So don't give up hope. I'm going to walk down here. Did anybody talk down this side of their group? I'm going to stand down here for a little bit. So I heard Dr. Maddox say that the heart's kind of like an electric eel. And it tells you the difference between cardiac surgeons and cardiologists. As a cardiac surgeon, the heart to me looks like a heart. And to the cardiologist, it looks like an eel, I guess. I don't know. Maybe. Oh, you don't have a microphone anymore. Well, there you go. So I want to start with a story. A guy takes his duck. Guy has a pet duck. He's had him for like 32 years. And the pet duck hasn't looked that good for a couple of days. And he takes the duck, puts him in a little box, and takes it to the veterinarian. And he asks the veterinarian, he says, look, this is my duck. It used to be a mallard. It lost little feathers. He hasn't looked well for a while. I want to know what's wrong with it. And the veterinarian looks at the duck. He goes, well, the duck's dead. The guy says, well, I don't believe it. He goes, oh, yeah, it's dead. He goes, well, come on. This is my favorite duck. He goes, well, hang on. So he whistles for his dog, and this beautiful black Labrador retriever comes in the room and wagging his tail and looks at the duck in the box and looks up at the vet and shakes his head like this, and out he goes. And along with the dog came this little kitten, and the kitten kind of looks in the box too and shakes his head and walks off, and the veterinarian says, well, it's right, it's confirmed your duck's dead. And he goes, oh, that's very disappointing. He goes, well, here's a bill for $1,000. The guy says, $1,000 to tell me my duck is dead? He goes, well, it's going to be $5, but for the lab work and the CAT scan. So, I stole that joke from one of my anesthesiologists. I am going to blast through this presentation because at the end of this talk, I'll be tempted to say the heart's kind of like an electric eel, and I've promised myself never to say that. And this talk, at the end, what we're going to come to agreement is that atrial fibrillation is an electrical phenomenon of the heart that changes its contractile properties of the atrium. Because of that change, the efficiency of the heart, the regulation of the heart rate are off and can cause troubles. And because the atria are still and quiver, they then can form a nidus for clot, and that clot can break loose and go downstream and cause a stroke. And so the two main problems with atrial fibrillation from a practical standpoint are the risk of stroke and the abnormalities of heart rate. And that at the end, again, this is starting with the end in mind here, at the end of all the talk, we'll come down to say, if you're in atrial fibrillation, first of all, if you're alive, your risk for atrial fibrillation increases every day, not by much. If you're in atrial fibrillation and don't have either rate or rhythm control that are acceptable, there may be a surgical option. There may be new electrical options later. And also it's a demonstration, or at least a sharing of people who are involved in our program, either because you live in our community or and I can't make eye contact because of federal laws about having a previous surgery. I can't share that without express permission, but you know, it may be something that we are learning, practicing, and trying to develop our skills and the lists of things that we can offer our patients. AFib, we said that. It's an abnormal rhythm, and the rhythm is usually fast. And atrial fibrillation symptoms, if you say, well, how do I know it? Well, everybody gets, we hope, fast heartbeats when they exercise, and sometimes you'll feel palpitations or a very rapid heart rate, which the shortness of breath is because the pump function doesn't work very well. Some people have palpitations, some people feel dizzy, some people faint, and some people don't feel a thing at all and just show up with atrial fibrillation with a normal rhythm and a stroke. First presentation can be stroke. Most common risks, well, these kind of look like things we've talked about, except there's probably not much in the previous presentations about alcohol ingestion. That's heavy alcohol use. We are proponents of, I got to see how I word this. We're proponents of taking bioflavonoids as dietary supplements, and you can get those in grape juice or red wine, or I don't know, eating spinach or something. Heart disease, structural heart disease, is probably the most common predisposition for atrial fibrillation. It's certainly the context in which I see it most of the time as a heart surgeon. The mitral valve especially predisposes to atrial fibrillation, either if it's leaky or stuck. And we will often do, or I'm almost always now, add a surgical procedure called the maze to re-regulate that heart rhythm. And the problem with the maze is that it's only successful in maybe 50 to 80% of the time, depending on what studies you look at. So atrial fibrillation has been a lot in the news lately. It's one of the most easiest preventable causes of stroke that we have. It has a 5-fold increase in the risk of stroke. And this is really interesting, this 2-fold increase in the risk of death. That's all-cause mortality, which is sort of interesting. That means that if you have atrial fibrillation and your twin brother or twin sister doesn't, and you're otherwise the same, your relative risk for death is twice that of your sister or brother on any given day. Annual health care cost is $6 billion. Remember the CAT scan on the duck? It's expensive. The atria actually are at the place where the rhythm is generated. And so it's way up here, and any attempts for us to re-regulate rhythm had to do with the atrium. This is the problem in atrial fibrillation is the heart rate goes fast and it loses the priming function of the atrium. So if the atria beat normally, they act as a priming pump. So they will do what's called preload the ventricle. So they actually add for any given heartbeat about 20% blood volume or 20% efficiency for each heartbeat. So if your heart rate's at 100 and you're pumping 100 gallons of blood a minute, it wouldn't, but it is. If you add the atrial kick, you're at 120. Said another way, if you're at 100 and you lose your atrial kick, you're at 80. Well, it's probably fine unless you have an otherwise weak heart, which atrial fibrillation can lead to. So it has some important issues to deal with in terms of fitness and health. There are 3 basic categories of atrial fibrillation. They include paroxysmal, persistent, and permanent. These categories have more to do with the likelihood of successful treatment or conversion of atrial fibrillation to sinus rhythm, and the definitions are there. The diagnosis is pretty straightforward. Holter monitor is just a fancy pants electrocardiogram over a period of time. And Holter himself is from Helena, Montana, and it's pretty famous, kind of a nice thing to know. And I don't know if Holter Dam has anything to do with that guy. Anybody know? No? Anyway, native Montanan, Holter monitor is used all over the world. Patient-physician choices, there's a little bit of a misnomer. There are physician mandates, requirements of your doctors, and there are some patient choices. As your physicians, we are required to tell you about the risk of stroke, to tell you about the risk of pump damage, late pump damage for lack of rhythm or rate control, to tell you about the appropriate therapy, which is your heart rate needs to be regulated between 60 and 100 beats a minute by your physician, your partner in this thing. And the risk for atrial fibrillation absolutely needs to be addressed, and it needs to be ameliorated as much as possible with the treatment of anticoagulation, Coumadin. The choices, there are some choices then, which I didn't want to oversell the choices. Choices right now are, of course, you try and attempt to restore rhythm, and that's automatic. Sometimes you can use drugs that can be very effective. Other drugs are risky, and those are things you have to talk about with your cardiologist. There are some, this is non-surgical, there are some ablation attempts. Some rhythms are amenable to percutaneous or catheter-based therapies, which can help re-regulate the electrical activity. And then there are some surgical operations. The maze procedure, named after a rat's maze, invented and designed by a guy named Jim Cox back in the late 80s, after a long time in the lab. And there are some newer approaches, minimally invasive, and that's what we're working on here, trying to learn the role for that a little bit and get the surgical options to be expanded a little bit. The full maze procedure is done as an open heart procedure. We did one 2 days ago, actually yesterday, as part of the major part of this person's operation, but they had to go in there for another reason. Minimally invasive or standalone AFib procedures aren't really the maze operation, and they have less success than a regular maze, but can be useful in some circumstances. You know, we always talk about the risk and benefit of any procedure. The benefit of the maze procedure has been fairly fixed, less than optimal. 90%, some people who, in very selected patients, overall efficacy or effectiveness may be 75%, and that's over a short period of observation. So the benefit's been less than what we'd want, and the risk was relatively high as a standalone procedure. So what we've been doing, and industry's been doing, and surgery's trying to do is say, well, if we can't make it a more successful operation, well, gosh, if we make it just non-risky, then maybe we can apply that benefit to more people. And so it's been the risk side that's been attacked over the last several years. The benefit actually hasn't been any greater, and we're still talking. In fact, I talked to Dr. Jim Cox Monday evening, rather, at a national meeting, and he admits that, you know, yeah, the benefits of the new operations aren't anywhere near what they were before, but the risk is so much lower that they're applying it more freely. We wish nobody had AFib, but cardioversion is pretty simple and straightforward, and most people with atrial fibrillation should have at least had an attempt at cardioversion and probable medical management of the rhythm. Risks of cardioversion, self-explanatory. Drug therapy, they don't cure but may control or treat the symptoms of the irregular heartbeat. Some of the drugs are very effective for some of the atrial fibrillation. Some are not very effective and fairly high risk. All of these things can be played out, at least walked through from its inception to its logical treatment with somebody that has insight and training into the drugs. Coumadin, by now almost everybody sitting in this room should know about Coumadin, or probably does, or knows somebody on it, or maybe even is on it. Has its own risks. Let me step out of my talk for a second. If you're on Coumadin, I might get in trouble for this, so everybody raise your hand if you promise you won't say who said this. Everybody? Raise your hand. I can promise, because this is going to make your doctors mad. If you're not on if you're on Coumadin and are not on a home monitoring, self-monitoring Coumadin-based system, you should talk with your physician about it. There's good evidence to suggest that Coumadin management is best done on a home monitoring system. A patient does it weekly and then reports that with their doctor, that team together, that mechanism, point of service in the house, if they're able, leads to far less Coumadin-related complications than any other means of doing it today. The machines aren't cheap, and not all insurance companies pay for it, but those are side arguments. So anyway, so remember, deny who said it, but ask your doctors about it. Obviously, not everybody can take Coumadin. When you're a surgeon, then it helps people. We like to operate. We think it's beneficial in most cases, sometimes not. But so Coumadin is, we dwell a little bit on the risks of Coumadin, but everybody pretty much knows those. This is a catheter-based approach. That's in the heart catheterization lab. We try and isolate the pulmonary veins. And a successful or full maze operation actually is not available right now percutaneously, but several procedures are, which may or may not be useful. They have some risk profile that I don't really talk about because I don't do this operation, but our electrophysiologist has elected not to do this. We are getting a new 3D mapping system. In the next year or so, we should be able to have a three-dimensional array and display of exactly where the catheters are, and it may facilitate better therapy for the less invasive platform. This is the maze procedure. It's an open operation where we take, and the same principles apply, where we try and control the sources of origin for the atrial fibrillation and then control how the electrical wave moves through the heart, and we attempt to restore rhythm. The best reported results long-term are 90% in a subset of patients. 96% is, we look at these small reports. We reported a series of 36 patients with maze procedures, 96% accuracy. You know why they chose 36? Because patient 0 didn't work and patient 37 didn't work. So you get those out of there, you got one patient to deal with, now you can report your results short term. Be suspicious always about results that are short term and small numbers, and that is not the right number, sorry. The risk of surgery is coming down, depends on the procedure, depends on what else you're having, and also depends on the surgeons. We're trying to develop a program that we could do this in a minimally invasive way, but we're not there quite yet. This would be the procedure. We'd use a thoracoscopic approach, small incision for port access, videotape or video camera, and then a small incision so that we can actually introduce the instruments directly into the heart or into the chest, around the heart. The heart's not stopped, it's a beating heart, and it's a couple of days in the hospital. And this number here, 85 to 91%, that's in a very selected subset. So not everybody in atrial fibrillation, in fact, people in chronic atrial fibrillation, that number is probably 50%. So this is a very select subset. I don't want you going out of here thinking, oh yeah, surgically can be cured 90% of the time. Maxwell said so. There are risks to that procedure. There's been some deaths reported, which is a pretty bad deal if you've gone in because you don't like your heart racing and you don't come home. And that's that's a horrible thing. I'm always reminded when we meet like this in a group that many people, and I see people that I've operated on or know or had successes with, I'm also mindful of the people that we've tried to help and come up short. And we take a minute and we think about those people who have been operated on or had medical therapy or aren't here with us today, or in rare cases made worse by what we've tried to do to help. It is important that we pay respect and honor the risks of the things that we do. This is a riskier operation than probably a standalone atrial fibrillation would be in the short term. So, conclusions. Remember we talked about that before we got here, that the conclusion is that atrial fibrillation is a funny heart rhythm that brings with it risks in terms of long-term heart health, strength of contraction, beating of the heart, and also the risk of stroke. And it needs to be addressed, period. Atrial fibrillation, if you or somebody else you know has it, that atrial fibrillation cannot be safely ignored. And the two components of therapy are rate control or rhythm control, either one of those two arms, and stroke risk reduction. And each person needs to have a plan to achieve those things worked out with their doctor. And somebody I heard, I don't even remember where I heard this before, but there's a home Coumadin monitoring system. Anybody have heard about that before? Home Coumadin monitoring might be better. Do you remember where you heard it? Anybody that comes to the operating room with AFib and a mitral valve disease has an operation because it's simple and doesn't add that much risk to the operation. And in the back of our heads, it may make their medical management, should the surgical therapy fail, it may make their medical management more efficient. One of the things that we like to embrace here and would really like to get over is this sense of prevention. Here we are in I think this building costs $60 million. Hospital, the cost of medical care, my duck joke, cost of medical care is obscene. And it's almost as bad as the cost of college. So preventive strategies are maybe what is most fruitful, but we don't get much money for eating soybeans. There's a full-pronged approach. If you look back at the risks, atherosclerotic coronary disease, prevention of scarlet fever, strep throat, and so forth are important adjuncts to prevention of atrial fibrillation 60 years down the line. 10 years from now, we're trying to do mitral valve surgery with through very small port access. There are lots of surgical things in the market, but AFib right now is therapy-based, and so there's investigations about therapy. Prevention is where we should go, and I don't know what's on there for that. The problem with atrial fibrillation is a stroke risk, and intermittent atrial fibrillation has a very high stroke risk because what happens is, it depends on how long you're in atrial fibrillation, if you form a clot and the atrium sits there and quivers and doesn't eject that clot, the body can remold that clot and keep the risk of stroke low. If you form a clot and then go back in a rhythm and that atrium kicks, that's when the clot goes out. And so intermittent atrial fibrillation is a high stroke risk, actually. Higher in some studies, of course, there's age and there's other things. But that absolutely needs to be addressed. And we're actually, this isn't an advertisement for work, but we're trying to develop a center for excellence in atrial fibrillation that would include cardiology, guidance, electrophysiologist, maybe a general internist, certainly pharmacy, Coumadin management, and surgeons to try and look at those things and keep abreast of, he asked what's on the market. Things change. The recommendations today are different than they were 4 years ago. But intermittent atrial fibrillation or paroxysmal atrial fibrillation carries with a significant risk for stroke. It's also in the best group for surgical results, and it ought to be talked about with your regular internist. And like everything, if you don't like the answer your doctors give you, ask somebody else. Get a second opinion. I have people second opinions regularly. The likelihood that you know how long you're in atrial fibrillation without monitoring is pretty low, despite how much you might know your body. It's an interesting thing that people with atrial fibrillation, intermittent atrial fibrillation, with a Holter monitor and a trigger so they can mark when they think they're normal rhythm, when they're not, you can flip a coin. If I have intermittent atrial fibrillation, is that serious? Answer is, it is serious and absolutely needs evaluation. Whether it's 5 hours or 24 hours is an important distinction, but that needs to be worked out in a very specific medical case. If we had a therapy that was 100% successful, we would all accept a little higher risk. We're looking at 50 to 80%. That isn't that great, frankly, not based on, if I did an operation with a 50% success rate in the operating room on the open heart, I get to do it one more day before the police take me away. So it's a little different world, but the answer is there wouldn't be anything restrictive in that scenario. Now, I want to tell you just one story because I can't really tell you the stories, but I came here 9 years ago. They asked me, well, why'd you come here? Well, I came here to study with Dr. Carlos Duran, who is a phenomenal guy. He's not here. He's in Mexico, I think, and I imagine him in a thong or something. No, I imagine him relaxed, tanned, and he's an amazing guy, and it reminds us all what a lifetime of dedication to answering questions about the heart is. And that's what his legacy is and continues to be. I came here 9 years ago thinking I would study for a year or two and then leave. And I came pretty wet behind the ears. And my first night on call came a call to see Kelsa. Kelsa, you can stand up. Thank God she's alive. Hi, Kelsa. My first night on call, I have to see this woman who had been in the hospital for a couple days, had chest pain, previous heart surgery, and she had torn her aorta, which if she hadn't had previous heart surgery would be hard enough. And it was an impossible situation. And so I said, well, we got to operate, and let me just call one of the senior surgeons because I need help because, oh, what the hell, it's scary. And I called a surgeon, and he said, well, I'm on my horse, Montana, you know, we all love it. I'm out horseback riding. There's no way I can come in to help. Good luck. And I think, Kelsa, I owe you a debt of gratitude because 9 years later, I'm a hell of a lot better surgeon than I was, but we might have got lucky, so thank you very much. We appreciate very much the opportunity to serve as your physicians, counselors, friends in many cases, and we take our obligations very, very seriously to try and get you the right information, try and do the right thing for the right times. And I guarantee you the efforts of our team, which is huge, important, and dedicated. And I want to thank very specifically, personally, and especially since I was a naughty boy a couple days in the operating room a couple days ago and was grumpy with somebody, and I had to send them an apology card. That's how seriously we take it sometimes, that we get grumpy. But I want to thank the cath lab, the wards, the ICU, the operating room, my colleagues, cardiology, non-cardiology, and surgical colleagues. And I want to thank the supporters of this meeting, our commercial sponsors, American Heart Institute, and especially the people who have put this program together, Beth and Lisa and Terry and Sharon Welsh. You have done a terrific job. Thank you very much, and thanks for your attention.
Our next speaker is Carol Benson. She's the Director of Emergency Services and Life Flight at St. Pat's Hospital. She's going to be talking about excellent heart care no matter where you live.
So you are a patient that has chest pain, and you could be anywhere. You could be down the block, you could be in this lobby out here today, you could be in a different town in Montana, and you are experiencing chest pain. And if you walk away from nothing from what I say today, I would tell you the first thing you need to do is call 911 and get to an emergency department, because that time to get to that procedure that Dr. Sands and Dr. Maddox described for you earlier and actually demonstrated for you is very critical. So I could tell you all the signs and symptoms of a heart attack. You probably have heard that a number of different times. But if you're having any of those symptoms, that shortness of breath, that tightness in your chest, the pain in your jaw, down your arm, all of those different kinds of symptoms that you might have, the first thing you need to do is call 911 and they'll access you to an emergency department as soon as possible, because that's where you can get the care that you need. And it doesn't matter what town you're in order to be able to have that access for the care. So there are links that happen. All of the other outstate, there are many other hospitals in other areas of the region that have a link with St. Pat's through the cardiac outreach. From one perspective is, and I'll talk about a few of them here, but has to do with having access to your EKG. So you come into the emergency department, the first thing they're going to do for you, and things happen very fast. It's very scary, and I'll talk a little bit about what will happen if you come into our emergency department here. But it's very scary because you're having this pain and people are running in a flurry around you and you have a whole bunch of people doing a lot of different things to you and they're taking your clothes off and they're slapping stickers on you because the most critical thing that we need to do is identify what's happening with your heart. And so what we'll do is we'll do an EKG. And the electrocardiogram will tell us, and we're able to give that to the emergency physician for them to be able to make a determination about what's actually happening with your heart. Because that will help us, and again, whether you're here or in another hospital, it helps us determine what mechanism of treatment you need to have to help alleviate that pain. So one of the advantages if you went to any other hospital, and I'll show you a picture of those in a minute, is that when they do this EKG, it actually links into the system here at St. Pat's in 20 different cities in Montana. And our cardiologists then have the ability to be able to review that, or if you happen to go into one of those hospitals, they can look up an old EKG so that we would have information on what your cardiac history has been in the past. Is there a change from your existing EKG to what it is right now? So if you had an EKG in another town and you happen to come here, they can pull that up and look at that information, which is really critical because we can tell if there's been a change in what's happening with your heart in the meantime. So the other thing that it does is it helps us access those experts that are here. These are the different towns that we have that link with the EKGs to be able to have access to your history if they're hooked into our network to be able to send those to us. That also includes the Holter monitoring system that Dr. Maxwell spoke about, and that also will link in here to St. Pat's also. So you have this EKG, and I'll admit I stole these slides too. So you have this EKG, we're able to review that. That cardiologist in that, or that emergency physician in that other hospital someplace else calls our cardiologist in our emergency department and said, I have a patient that's having an acute MI, we need to get them to your hospital right away. Because they may not have the services that the cath lab provides here to be able to treat the problem that you're having. And so they will contact us, the cardiologist speaks with them, and then what they'll do is they'll contact Lifelight to come and get you. And this is my plug for Lifelight, and I'm taking full advantage of it. In 2006, Lifelight flew 796 patients. We actually had over 1,300 requests. Some of those ended up not needing to be flown, or we went and they couldn't be flown because of the weather, some different things like that. And sometimes we respond for 911 whether they need us or not. That's just the way our emergency system is set up in Missoula County. And so of those, 465 of them came by helicopter and the other 277 came by plane. So you may not know that we also have a plane that can fly you here. So we can go to Anaconda and pick you up and bring you back, sometimes quicker than we can in the helicopter. So Lifelight is set up to come and go and pick you up, to bring you back. Of these 700 and some patients, 35% of those are cardiac patients. The advantage to you is that this crew, this medical crew that's picking you up, are experts. These are nurses and paramedics who have flown. Lifelight's been around for 25 years. I think we have an average of about 18 years of flight experience among the crew. So we have a huge amount of experience to be able to make sure you're taking care of the best stuff while you're in that flight. So they will bring you then to St. Pat's, and you may go to the emergency department, you may go directly to the cath lab depending on what information has been provided to us. So if Dr. Sands or Dr. Maddox have gotten that call, they may just let them know that they'll go directly to the cath lab and then they'll just land on the roof and come right down and drop you off in there. So you bypass the emergency department altogether. Here at St. Pat's, we are an accredited chest pain center, we are the only accredited chest pain center in the state of Montana. The other new program that we're implementing, and actually it's really not new, we're just kind of putting a name to it, is a level 1 MI program. And this is where I would describe to you that when you come into the emergency department, things happen very quickly. So believe it or not, a lot of people with chest pain walk into the emergency department. And isn't that kind of scary that someone with chest pain drives to the emergency department? So that's why I said call 911, because then they'll give you the opportunity. They will come there, they'll get you on a monitor, and they can give you medications to be able to get into the emergency department. And soon we will have access that if an EKG is done in the field through Missoula Emergency Services or through Lifelight, that can be sent to our emergency department for our emergency physician to have access to be able to get the balls rolling, to have the team here to respond if there's a need for the cath lab to be able to come in. So we're calling this a level 1 MI program because it's very critical, and we have a very high emphasis of importance on it. Again, I talked about that EKG. They're taking your clothes off, they're getting you set up, and then we implement those processes so that within 20 minutes from our call, the cath lab is here to be able to be ready to start doing that procedure for you. And our goal is that from the minute you walk in this door to when you get to that procedure that Dr. Sands performed earlier would be within 60 minutes. Ideally, we would like it to be even less than that. And so that's why when you begin having that chest pain, and you saw Dr. Maddox had the slides that women wait 198 minutes and men 138 minutes before they even come to the emergency department, a lot of damage can happen in that meantime. So it's important that you get in and access that EMS as soon as you can. Other outreach programs that we have include mobile echocardiograms, and we do about 1,000 of those annually. And we do both regular echoes and stress echoes. We do them in Anaconda, Superior, Deer Lodge, at the prison, and in Phillipsburg, and in many other towns also, but they've actually expanded some of the services in those areas. The exams are read by Missoula cardiologists, and for the last 3 years, the exams have been stored electronically here at St. Pat's, so that again, we have that history of what your previous cardiac care has been and the kind of treatment and the testing that you've been done. So example here is that if you had an exam done in Dillon, you can compare it to one that was done in Plains, or if you presented to an emergency department someplace else or needed cardiac care. So just to kind of, I guess in summary, we have one of our other things we want to do is expand that level 1 program to other hospitals that refer patients to us. So that if you were happen to walk into one of the other regional hospitals, the same steps that would happen here at St. Pat's in our emergency department would happen out there, so that we would access life flight to get you here as quickly as possible, or a ground ambulance if we needed to, and they would start all of those treatments and procedures that you would have when you came here, the different medications you needed to have, getting that EKG here also. And then also more expansion of our telemedicine program, where we're able to communicate and do consultations with physicians and patients in other hospitals throughout the region, and there are a number of hospitals that are participating in that. Well, thank you. I appreciate you taking the time to let me speak.
This is our telemedicine setup that they're able to control this camera.
Dean is actually the leading physician in Plains, Montana, and we are fortunate to really believe strongly in a team approach to the care of patients. While I would venture to say most of you are from Missoula, some of you aren't, and I can tell you that approximately 60% of the volume at St. Patrick Hospital comes from outside Missoula County. If you think about that, that means we really, in order to provide optimal care, need to depend on our partners, of which Dean is one of the preeminent examples in each of the rural communities surrounding us. And that means not only that the physicians talk, but we really, in order to provide care to patients, have thought long and hard about how to deliver care in distant places.
David, how are you doing?
I'm doing very well.
David's a patient of mine. He presented with chest pain and underwent angioplasty of his right coronary artery, which was a rocky procedure but is done well. I looked at your echocardiogram. It looks terrific.
For the audience, it's important to know that some of you have had tests done here at St. Pat's, and as I think Carol Benson did a nice job explaining that we do tests elsewhere, but what's probably hard to believe is that that is one of the most state-of-the-art machines in Montana that Dr. French purchased in the last year. They do the tests up there, and then they're transmitted here, can be real-time, and they're certainly all read on the same day, and they can view them and we can view them simultaneously. I'm not sure, Dr. French, that we are set up down here to show that and you at the same time, so we may have to forgo that. Because the patient had one yesterday. We were going to try to do that, but with the speed of the connection right now, that's probably not going to work. What we would like to do is, obviously we can talk to him, and usually the connection, the audio is perfect, I'll tell you that. It's just that we're having a little conflict with this emergency scan. But what we went further with was setting up for a physical examination, And Dan, if you're okay with it, we're going to listen to your lungs and heart here. Dr. French is going to help us with that. We have a digital stethoscope. So you, the audience, will hear everything we hear. Let's do his lungs. Take a listen to his lungs. Sure.
We're able to hear very clearly as if we were listening. You also can zoom in. I had a patient that I put a pacemaker in and had a stitch out, and we zoomed in, looked at the stitch, and I said to the nurse, you need to pull that. Just pulled it from up there. And they would have had to drive from Shelby to have that done.
Advantages, of course, are for the patient. They don't have to travel minimum of 2 hours round trip, longer in the winter. Do you have questions for us, Mr. Schott?
No, I don't have any at this time.
Okay. I know you wanted to say how wonderful Dr. Maddox is. So.
Essentially, you did a very good job. Thank you.
And we really appreciate your doing this because it's not, it's above and beyond the call of duty.
Yeah.
And Dr. French, I have to say, has been one of our best partners. He has spent a lot of time working with us trying to get all this sorted out and make sure that this works for both the benefit of the patients and the hospital. And Dean, in the next 2 weeks, I expect us to shift over here to this room so that we can start doing continuing medical education together.
That'd be great.
Good.
Anything you want to impart to the audience?
No, I just think as we advance, this really brings communities closer together, medical communities closer together. It allows us to bring better care out to the rural areas. All of David's studies leading to Dr. Maddox's interventions were able to be performed here, transmitted down there. We were able to make timely, quick, right decisions to get him great care. And that's what this is all about.
Good. Your audio came across great there. It looks like MR scan's done.
Cool.
All right. Again, thanks very much.
Thank you.
Thanks, Dave.